Hi, Professor Aguirre. Are you there?
Good morning.
Morning.
Good morning now. Good afternoon to you.
Jakarta. Okay, Professor Harmani, are you there?
Thank you very much.
Okay.
I'm
Okay.
here.
Is my voice clearly heard?
Yes.
Okay. Can we start now? Anybody? Okay. Let me open with our language Bahasa Indonesia first, just to make our audience relax. Oke. Sejauh sekalian, Assalamualaikum warahmatullahi wabarakatuh. Selamat siang, salam sejahtera untuk kita semua. Selamat datang di webinar yang diadakan oleh Yayasan Cardiovascular, Departemen Kardiologi dan Kedokteran Vaskular, Fakultas Kedokteran Universitas Indonesia, Rumah Sakit Jantung dan Pembuluh Darah Harapan Kita, Pusat Jantung Nasional, serta juga dengan Rumah Sakit Pendidikan juga Rumah Sakit Universitas Indonesia. Selamat datang. Semoga bertemu sejawat semua dalam keadaan sehat, baik pada era pandemi ini. Saya Renan Sukmawan, Ketua Departemen Kardiologi dan Kedokteran Vaskular FKUI di Rumah Sakit Jantung dan Pembuluh Darah Harapan Kita. Saya tahu situasinya sekarang kita berada di tengah pandemi, tapi apapun kita terus menambah ilmu kita, banyak konsep-konsep yang terus kita dalami terkait dengan aterosklerosis, baik di pembuluh darah koroner maupun pembuluh darah otak, ya, dan tidak terlepas dari problem dislipidemia. Dan hari ini kita ada dua pakar yang sudah malang melintang di dunia lipid ini, dan kita akan diskusi. Silahkan nanti kalau ada pertanyaan apapun, silahkan disampaikan, bisa lewat chat atau QA saja. Dan karena suasananya minggu, kita semua make relax saja, teman-teman, sambil belajar, sambil silahkan kalau situasinya tentu teman-teman berada sambil di tengah-tengah keluarga, ya, sambil berkumpul atau sambil ngopi, begitu ya. Make free, jadi bikin suasananya relax saja. Tapi kita bisa berdiskusi dalam. Silahkan kalau ada pertanyaan yang ada. So, my colleagues, ladies and gentlemen, it's a pleasure for me to be with you here today, to meet you all, in the hope that you all in very good condition, safe. We know we are in the midst of pandemic, but again, yet we need to provide the best care we have to our patient. So today, our topics entitled Non-HDL management to reduce cardiovascular risk. We have two well-known speakers. One is our guest speaker, Professor Carlos Aguirre from Portugal. He's a well-known expert throughout the world, and he has talked lots in this field. And also we have Professor Hamani, who also have lots of experience, lots of publication also, give seminars and also lecture on this field as well. So for the first topics, we will discussing about the deeper and the concept of optimizing cardiovascular risk reduction beyond HDL cholesterol. As you know, we are dealing with, in daily practice, we always see the list of cholesterol components that we always see in patient's sheet or coming from laboratory, seeing the total cholesterol, HDL, LDL, and triglyceride. And always come to our question, which is the most important, and is this important to consider one or these two or three which components to be considered when we are going to treat our patients in the front of us. So with us today, we have Professor Carlos Aguirre from Portugal. And this is actually my CV, and This is Professor Aguilar CP. Please, we can see here, he's now consultant cardiologist at the Hospital of Santa Cruz in Lisbon, Portugal, working at the physician of cardiac intensive care unit, advanced heart failure also, and chairman of cardio oncology clinics, and lot of experience as appointment in the Department of Internal Medicine, cardiology, member of Portuguese health technology, and we can see also lots of appointment and experience. He also had an experience as, and even until now, as advisor of Health Ministry National Program for Cardiovascular and Cerebrovascular Disease. Again, this program is brought to you under collaboration of Yayasan Cardiovascular, Cardiovascular Foundation of Indonesia, and Department of Cardiology and Vascular Medicine, University of Indonesia at Harapan Kisana Heart Center, and University of Indonesia Hospital, with the support from Abbott. And thank you again for support of Abbott for this program, in the hope that we can have a great discussion. We hope that you can have insight from this today's discussion. Please feel free to put your question in at the QA. Just type your question soon. When you have question, just type it, whether to first speaker or the second speaker. And if you want, you can put also in Bahasa Indonesia, our language, so we can have discussion on this. Make everything easy and relaxed in this Sunday's webinar. Okay, without long ado, I would like ask Professor Aguilar to start his lecture. Please, Professor Aguilar.
Thank you, Dr. Renan. Good morning here, good afternoon there to all of you. Good afternoon to Professor Harmani. Thank you very much for the privilege of having me participate in your international symposium. And I hope it's going to be a nice discussion around how we can use our best opportunities to prevent cardiovascular disease. The pandemic has been one of the biggest concerns all of us around the world have faced, but cardiovascular disease remains the #1 cause of death. Now I'm going to share my slides. Hopefully you can see them now. These are my disclosures regarding the contents of this presentation. And I want to start off by reminding everyone of how important cardiovascular disease is to overall mortality, and also to highlight that cardiovascular disease is no longer a problem of the Western world. In fact, when we look at age-standardized mortality rates for cardiovascular disease over the more recent years, we actually see that the burden of cardiovascular disease fatality is higher among the eastern parts of the world. And here in Indonesia, where you are at the moment, this is already a much higher risk for cardiovascular disease country than many of the so-called Western countries like Portugal, where I come from. Now, when we look at how cardiovascular disease can be prevented, we have recognized for a long time since the Framingham Heart Study that there are several risk factors for cardiovascular disease. One of them is dyslipidemia. And dyslipidemia is responsible for a very big part of cardiovascular disease. When we specifically look at myocardial infarctions, we realize that about 50%, almost 50% of all myocardial infarctions are due to lipid abnormalities. And so if we were able to diagnose and correct by treatment and lifestyle interventions dyslipidemia in everyone who has dyslipidemia, we would be able to reduce by half the total number of myocardial infarctions we see. Another thing I would like to remind everyone on is that we have been seeing changes in the way cardiovascular disease has been presenting itself in our hospitals and in our outpatient clinic. For example, we've seen a change in the pathophysiology of acute coronary syndromes. By the way, our neurology colleagues also say that there has been a change in the pathophysiology of ischemic strokes. And this is in part related to the fact that statins are already being used quite a lot in primary prevention around the world, and statins modify the atherosclerotic lesion. And on the other hand, it's due to the fact that the demographics and the risk profile of patients who nowadays are being admitted both for acute myocardial infarction and acute ischemic stroke has changed. We now see even younger patients having these problems. More women are coming in for acute coronary syndromes. Many times they have insulin resistance or diabetes, high levels of triglycerides, and very importantly, they often are being admitted despite taking statin therapy and their LDL being rather low. So this really shows to us that being on a statin is not a guarantee that you will not have cardiovascular disease and cardiovascular mortality. Now, this new type of patient is the type of patient which is becoming more and more commonly found in our clinics and in our intensive care units and wards, is the patient who has atherogenic dyslipidemia. This is a dyslipidemia where we find an increased number of atherogenic lipoproteins and a reduction in the amount of anti-atherogenic lipoproteins. LDL cholesterol in these patients can be even normal or only moderately increased. We do, however, see high levels of triglycerides and low levels of HDL. A particularly striking feature about the LDL in these patients is that although there might be not too much in quantity, the quality of this LDL is very dangerous, as it is predominantly in the form of small, dense lipoprotein particles, which we know are much more atherogenic. Now, atherogenic dyslipidemia is something we should all be afraid of, and we should be aware of, and making efforts to not allow it to be underdiagnosed. It is indeed a highly prevalent condition, even among statin-treated patients. There are numerous studies, observational data, contemporary to our times that have shown this. This is an example of data coming from the DICES study, where you see that about a third to over 40% of patients who have been taking or are taking a statin still have low HDL and high triglycerides. This is particularly common in type 2 diabetes. Now, atherogenic dyslipidemia is a big problem because it is very frequent, as I have just shown to you. About a third or even a little bit more of patients who are high risk for cardiovascular disease and are taking statin therapy have this type of lipid abnormalities. But we also need to recognize it because it is very dangerous. And this is shown nicely on this slide. This slide is on patients who have a rather well-controlled LDL below 2.1, taking statin therapy, and what the authors looked is to what was the risk of coronary heart disease over the several years of follow-up based on triglyceride levels and HDL levels. And they saw that even in this group of patients who had very well-controlled LDL, the higher the triglyceride was and the lower the HDL, the higher was the risk of having coronary heart disease. In fact, if you look well at the numbers on this table, that risk varied by about 10 times. Said in another way, you and I can have exactly the same LDL level, taking a statin, and both be very happy with that low LDL level we have. But you and I, based on our triglyceride levels and HDL levels, can be 1000% different as regards to our risk of having coronary heart disease. 1000% difference. So that really tells us that we cannot rely only on the LDL to fully prevent cardiovascular disease. Now, having shown to you that atherogenic dyslipidemia is common and it is dangerous, before I actually tell you how it should be treated, it's important to understand how it becomes dangerous, because that really helps us, think that the next time we see this, we really have to take care of these patients. I won't go into deeply about the pathophysiology of atherogenic dyslipidemia and how high triglycerides cause cardiovascular disease, but I want to explain to you how the pathophysiology is in one of the most simplest things that we can actually explain regarding this. Now, the pathophysiology of atherogenic dyslipidemia is very similar to that of insulin-resistant states. These patients have lots of free fatty acids available in the blood, which are taken up by the liver, and so VLDL particles are excreted and have huge amounts of triglycerides because of the large availability of free fatty acids in the blood. Now, whenever there is an excess of triglycerides in the blood, and an excess is above 150 milligrams per deciliter or above 1.7 millimoles per liter, a protein we have in our blood called cholesterol ester transfer protein, CETP, becomes active. Now, what does it do? It takes triglycerides from particles which are heavily packed with triglycerides and transfers them to particles that have got less amounts of triglycerides. In exchange, it does remove some of the cholesterol of these particles and puts it back into the other particle that had lots of triglycerides formerly. Now, this changes the composition and also the size of the LDL particles by becoming richer in triglycerides and losing cholesterol. They become smaller and denser and more atherogenic. Now, CETP does exactly the same thing with HDL. It also transfers the excess of triglycerides from the VLDLs to HDLs, in exchange giving back to LDLs cholesterol. And again, the HDL particle changes in composition and also in size. It also becomes smaller and denser. It is more rapidly cleared by the liver, by the kidney, and this is why in patients who have high triglycerides, we also typically see low HDL. Now, another thing that's going to change is the VLDL particle. So these patients that started off by having very large amounts of triglycerides in the VLDL, by losing triglycerides both to the HDL and to the LDL, become smaller and also richer in cholesterol. Now, the reason that they become smaller is by losing these triglycerides, and by becoming smaller, this is going to cause a problem, which I will explain to you in a few seconds. But let me start off by very simply reminding us of some basic things in atherosclerosis. What really causes atherosclerosis is cholesterol. We don't find triglycerides, at least in significant amounts, inside atherosclerotic lesions. What we find is cholesterol. And that is why we many times have some difficulties in understanding why triglycerides actually can cause cardiovascular disease. Another thing that is important is that cholesterol is the same. There's no such thing as bad or good cholesterol. It is all the same. What makes it good or bad is which is a lipoprotein particle that is transporting that cholesterol in the blood. Some of these particles take cholesterol from the liver to peripheral tissues. Others do it the other way around. The first can be dangerous. The second can be the good cholesterol. But a very important thing is that for cholesterol to cause atherosclerosis, the lipoprotein particle carrying the cholesterol needs to be sufficiently small to cross the endothelial barrier into the intima, where it becomes changed and retained, creating that atherosclerotic lesions. Now, this is what happens when triglyceride levels are normal. Under this situation, we do have most of the cholesterol inside the blood is in the LDL particle. There is small amounts of cholesterol also inside the VLDL particles. But this cholesterol, which is exactly the same as the one inside LDL, does not cause atherosclerosis because it is being carried by a lipoprotein particle that is too big to cross the endothelial wall. So in situations where triglyceride levels are normal, the only cholesterol that causes atherosclerosis is the one being carried by LDL. And because statins are very good at lowering cholesterol in LDL particles, statins are all that is enough to treat patients when triglyceride levels are normal. But this is what happens when triglyceride levels become mildly to moderately elevated. This is in between 150 and 500, or 1.7 and 5.7. Still, in these situations, most of the cholesterol carried in the blood is inside the LDL particle. However, these LDL particles now are more dangerous than the ones we have when triglyceride levels are normal because they are small and dense. The thing about being small and dense is that cholesterol is more easily modified once it gets into the arterial wall, carried by a small dense particle, and it becomes retained. In other words, it no longer can go back into the blood through HDL. So there it really becomes atherogenic and causes growth of that atherosclerotic lesion. Now, again, in these patients, we also see cholesterol inside those modified VLDL particles, which are called remnant VLDLs. As you may recall, these modified VLDL particles have actually become enriched in cholesterol because CETP took away triglycerides from these particles but gave back to them cholesterol. So we actually have an unusually high amount of cholesterol inside these particles. Now, the big problem, I said to you, is that they have shrinked. They have become smaller. And so now they can also cross the endothelial barrier. So this is the reason why patients who have atherogenic dyslipidemia have a higher risk of having cardiovascular disease than patients who only have a problem of LDL being high. It's because these patients with atherogenic dyslipidemia have not one, but two different sources of cholesterol being carried into the arterial wall. Now, unfortunately, statins are not good at lowering cholesterol inside the VLDL particles. And so statins are not enough to take care of all the cholesterol. They only take care of parts of the cholesterol that can cause cardiovascular disease in these patients. If I've elicited some interest and motivated you to want to know more about how triglyceride levels cause cardiovascular disease, let me tell you that there are many more mechanisms. And these are three articles that are nice reviews of all the things that triglycerides do in order to create an excess amount of cardiovascular disease. Now, this notion, this clarification that it is not only LDL that can carry cholesterol into the arterial wall, causing atherosclerosis, but also the modified other lipoprotein particles that contain ApoB, which are particularly the LDL, but also IDL, under the right conditions, in other words, when triglyceride levels are high, that led to the concept of non-HDL. In fact, it is not only LDL that can be bad, IDL and VLDL can also be bad. So everything that is not HDL can be bad. It is very easy to calculate non-HDL. You simply subtract the HDL level from the total cholesterol level. Any child in primary school can do that easily. The guidelines recommend that non-HDL is a secondary target of therapy. You'll see that just now. And our maximum recommended level for non-HDL is no more than 30 milligrams per deciliter above the LDL goal. If you're working in millimoles, it's no more than 0.8 millimoles per liter above the LDL goal. Now, there are many ways in which non-HDL really is more important than LDL in predicting the rate of progression of atherosclerosis. We have several studies showing that non-HDL is a better predictor of plaque growth velocity. It's also a better predictor of how much inflammation you see inside the plaques. It's a better predictor of coronary calcium progression and also a progression of atherosclerosis in the carotid arteries. So non-HDL is indeed a better predictor of the rate and the vulnerability of atherosclerotic lesions compared to LDL. And real-world studies have shown to us that non-HDL predicts cardiovascular disease indeed much better than LDL cholesterol. There are numerous studies over the past 10 years to show this. This is only one of those meta-analyses performed in the United States. And the authors of this meta-analysis, what they did then is then calculate what would happen if physicians in the United States would start looking at non-HDL cholesterol instead of only looking at LDL cholesterol to identify patients at high risk for cardiovascular disease. And they realized that in the United States alone, just in their country, if physicians were to look also at non-HDL and not only LDL, they would prevent 300,000 cardiovascular events over a 10-year period. There are enormous advantages to non-HDL cholesterol. It is also an indirect estimate of the LDL particle number, which we know is a better predictor than the concentration of cholesterol inside the LDL particles. It also makes no assumption on the relationship between VLDL and triglycerides. As I've shown to you, once triglyceride levels go above 150, VLDLs become contaminated with cholesterol and lose triglycerides. And so the Friedewald formula no longer starts being accurate. And that means that the LDL level we estimate from the Friedewald formula is actually going to be falsely low. And we think the patient is with a low LDL, but in fact, the patient does not have a low LDL. It also does not require fasting, very easily calculated and inexpensive, and can even be used to stratify the risk of patients even when they have severe hypertriglyceridemia. So this is why non-HDL cholesterol, for all these reasons, has been adopted by many guidelines around the world as a target of therapy. The European Society of Cardiology and European Atherosclerosis Society particularly recommend that we do not forget to calculate non-HDL cholesterol in patients who have high triglycerides, diabetes, obesity, or very low levels of LDL. These are the patients where if you do not look at non-HDL and only look at LDL, you will be misled. You will think your patient is well controlled as far as lipids go by only taking care of the LDL, and that is not true. It also recognizes, both societies, the importance of atherogenic dyslipidemia as a major risk factor for cardiovascular disease in type 2 diabetes, and says that the way to take care of this excess risk for cardiovascular disease in these patients is by doing lipid triglyceride lowering therapy as an add-on to statins. Now, the reason is that if I lower triglycerides, then no longer will CETP, that transfer protein, change the composition of VLDLs, LDLs, and HDLs. And if that doesn't happen, then VLDLs will always be too big to cause atherosclerosis. And the only cholesterol that will cause atherosclerosis is the one inside LDL. So the way to treat atherogenic dyslipidemia, as the guidelines say, is to lower triglycerides as an add-on to statin. And how can we lower triglycerides? There are two options: fibrates and omega-3 fatty acids. Fenofibrates and bezafibrates are the only fibrates recommended by the European Society of Cardiology guidelines. However, the only one that has been tested on top of a statin in phase 3 randomized controlled trials is fenofibrate. And a very important word on gemfibrozil: it is absolutely forbidden to use gemfibrozil on top of any statin. The other is omega-3 fatty acids, which we need to use at high doses, at least 2 and up to 4 grams per day. Now, there are many more guidelines. I just want to show to you another 2 that have adopted non-HDL cholesterol as a target of therapy. In the American Association for Clinical Endocrinology, non-HDL is as important as LDL as goals of therapy. They are co-primary targets of therapy. And in the United Kingdom, the NICE guidelines since 2016, so now for 5 years, they have been recommending non-HDL as the primary target of therapy, and they no longer even recommend that we look at LDL cholesterol, only look at non-HDL. Personally, I think we need to look at both, as the European guidelines tell us. So how do we treat atherogenic dyslipidemia? In this last part of my talk, I want to start off by highlighting that the most atherogenic lipoprotein particle in the blood is the LDL. It is the lipoprotein particle that carries the most amount of cholesterol, and it is the one that is small enough to cross the endothelial barrier and cause atherosclerosis. And so it is impossible to think about cardiovascular disease prevention without lowering LDL cholesterol. And we haven't found that value of LDL cholesterol below which it becomes dangerous to continue to lower LDL. Indeed, both in primary and secondary prevention, the rule seems to be the lower, the better. So statins, because they are very effective at lowering cholesterol inside LDL, they are the backbone of treatment of anybody who has got dyslipidemia and a high or very high risk of cardiovascular disease. Now, when it comes to treating atherogenic dyslipidemia, so if we have high triglycerides and low HDL and that LDL cholesterol is already well controlled, we need to lower the triglycerides. As I've said to you, fibrates and omega-3 fatty acids are among the most potent strategies to do this. The other one was niacin, which is discontinued in many parts of the world because niacin increased the risk of ischemic stroke. it also has several side effects and tolerability issues. And so it's no longer an option in the guidelines around the world. Now, fenofibrate is the only fibrate in Europe that we are allowed to add on top of a statin by regulatory authority. So by the European Medicines Agency, over the past 10 years, there is this rule that it's the only fibrate because of safety reasons. It has no interaction with any of the statins that we can use on top of any of the 7 statins available around the world. It has been studied in patients with type 2 diabetes in 2 large phase 3 trials, FIELD and ACORD-LIPID. The most important of these trials is ACORD-LIPID because in ACORD-LIPID, every patient included had to be on statin therapy. And we know today that there is no doubt, no reason to doubt the importance of statins to lower cardiovascular risk in type 2 diabetes. Now, unfortunately, there wasn't a concern about choosing patients to be included in the trial, in both of these trials, based on their triglyceride levels. There wasn't any inclusion criteria for triglyceride levels. And so half of the patients inside both of these trials had absolutely normal triglyceride levels. And if you recall those slides with the buses I showed to you some minutes ago, if triglyceride levels are normal, the only problem is LDL. So there's no reason to lower triglycerides. And that is why overall, because these trials included patients with normal triglycerides, the primary endpoint was only marginally reduced. This did not reach statistical significance. However, when looking at patients who did have atherogenic dyslipidemia inside these trials, this is where we saw very significant reductions in the rates of the primary endpoint, which was cardiovascular deaths, myocardial infarctions, and strokes, and also revascularizations. And this makes a lot of sense because it's when triglyceride levels are high that we get the need to lower them because they are contributing to that additional source of atherosclerosis. Now, this is also shown in a better way over here. So patients who did not have atherogenic dyslipidemia on the left, no benefit, also no harm of adding fenofibrate on top of the statin. If you do have atherogenic dyslipidemia, a significant reduction in the events. If you select patients based on the way guidelines are telling us, which is if your non-HDL cholesterol is more than 30 above the LDL, then this is where we see huge reductions in the rate of cardiovascular complications. So using non-HDL as a target and that 30 above the LDL level or 1.7 above the LDL level is really the best way to know which of your patients deserve combination of fenofibrate with the statin. Now, the primary endpoint in ACORD-LIPID was a composite of non-fatal and fatal events. And so this is to show you what happens regarding fatal events. Fatal cardiovascular disease was also significantly reduced in those patients with atherogenic dyslipidemia. So combination of fenofibrate and a statin in the right type 2 diabetes patient will improve life expectancy in these patients. It is certainly a treatment we should not refrain ourselves from giving to patients because it will increase their life expectancy. This is an important finding here in the ACORD study. So the ACORD-LIPID investigators, what they did is after the 5 years of randomized controlled trial, they invited all the survivors to continue to be observed in an extension study of another 5 years with no intervention. So this was an observation-only study. Now, because ACORD lipid had been a neutral trial, almost all of the patients that were taking fenofibrate in the fenofibrate arm were taken off fenofibrate, and so only the statin was left in both sides, in both arms. Despite being 5 years away from taking fenofibrate, so only being on a statin, those patients that had taken fenofibrate for those first 5 years of the ACORD lipid trial still continued to show the reduced rate of cardiovascular disease. It's like the arteries, our cardiovascular system keeps memory that it had been submitted to the beneficial effects of fenofibrate, and that memory keeps on there for several years, even after stopping the therapy. Another important update of this accordion extension study regards mortality. If you see here on the bottom left-hand side, this is total mortality over the next 5 years. So even when fenofibrate had been stopped and patients were left only on the statin, all-cause mortality was still lower among those patients that for 5 years had been treated with fenofibrate. Indeed, there is a legacy effect. So in conclusion, here are my take-home messages. Cholesterol plays a fundamental role in atherosclerotic cardiovascular disease. In many patients, the cholesterol-containing lipoprotein that causes atherosclerosis is the LDL. But in a significant, growing number of patients, and you in Indonesia have lots of increasing rates of obesity and diabetes, cholesterol carried by other lipoproteins beyond the LDL, which are those triglyceride-rich lipoprotein remnants, also contributes to atherosclerosis. This is why guidelines now also focus on non-HDL and not only on LDL, recognizing that these patients have a higher risk of cardiovascular disease than those who only have high LDL. And the way to remove that excess risk is by lowering those triglycerides. Statins will remain the first-line agents for lowering LDL, and they can even lower non-HDL, but they are not as good at lowering non-HDL as they are at lowering LDL. And so often, when your target for LDL has been reached, your non-HDL will still remain high. I want to remind you that it's about 30 to 40% of patients who have their LDL controlled that do not have the non-HDL controlled. This is where we need combination therapy to remove that excess risk of cardiovascular disease. Fenofibrate is the only fibrate that can be safely used in combination with statin. Omega-3 fatty acids are an alternative, and sometimes we may even need to combine both. Thank you for your kind attention.
Thank you, Professor Aguirre. It was a clear lecture and very informative explanation on the concept that should be integrated to our daily practice, such as atherogenic dyslipidemia and using non-HDL as at least co-targets with LDL when treating patients with dyslipidemia. And even in some country like UK, they use non-HDL as prime target, right? So this is very important concept that we have to pay attention, and we can discuss here, and then we can bring to our practice later on. So thank you very much, Professor Aguirre, and we'll looking for a discussion after this. And we will move for our second speaker that would more, yeah, this is a poll. Okay, we have a poll here. So please, how to do this poll? So there are questions on your, in your screen. Please choose, this question: which of the following is true about Portugal? Because we are from Portugal. Please choose one of the answer, please. Okay, yeah. And can you see the result? Yeah.
Yes, this is correct. All of the above is correct. We are the oldest country in Europe. In Lisbon, we have the oldest bookstore that is still open, continuously open in the world. We are famous for fado and piri piri, so the
piri
hot sauce, and also for football.
Yeah, Ronaldo.
And we have one of the oldest universities in the world, going back to the 13th century, that has continuously been open throughout all those centuries. So all of the above is the correct.
Could you tell us which is the world oldest bookstore and which one is the oldest university that you mentioned?
So the oldest bookstore in the world is called Livraria Bertrand, and it is in Lisbon, in a very nice, one of the nicest spots in Lisbon where tourists really like to come take some pictures. And the oldest university in the world is the Bologna University in Italy, in the northern part of Italy.
Okay. And Bologna in Italy, and one, so you mentioned, but one of the oldest. Is there any older university in Portugal?
No, we have the 6th oldest university in the world. It's in Coimbra, which is about 200 kilometers north of Portugal, of Lisbon. Sorry.
Yeah, it's Quinta University. Is that
Coimbra,
right?
Coimbra, which is where the fado music was born.
Oh, yeah. Okay, thank you very much. Just make us clear about Portugal, and hopefully soon after the pandemic over, then we can have a chance to see. Okay, then this another question on, could you please deliver this, Professor?
Yes,
this is from, please.
So this is a question on treatment choices. And so I want to know what you would do to this patient, a 60-year-old high-risk type 2 diabetic. Blood pressure is well controlled. Body weight is well, so body mass index is normal. She is on statin therapy, and her blood test results show her total cholesterol is 4.1, LDL is 1.8, HDL is 0.9, and triglycerides are 3.0. Would you only reinforce advice on lifestyle and diet and don't do any change in the medication? Or would you increase the statin dose or switch to a more potent statin? Would you prefer to add ezetimibe or to add fenofibrate or to add omega-3 fatty acids to that statin she is taking?
Okay, please choose one among the answers, list of answers, and then Professor Aguirre will describe more on this important case. I think this is our daily case, especially in Indonesia. Yeah, we do have lots of diabetes and also a patient with at least metabolic syndrome.
So I think the figures are quite stable, So the poll has ended, and most of you would add fenofibrate, which I think many of us would also agree on. And a considerable number of you would reinforce advice on diet and lifestyle. And I must agree that this is also important. In fact, by doing more exercise, by taking care of her diet, there is always ways in which we can reduce triglycerides. They are very modifiable by lifestyle interventions and diet. And we should always reinforce those advices on lifestyle and diet, even when we are changing therapy. So I think both of these two answers are together the right answer. She already has her LDL at target. So for a high-risk patient, guidelines are recommending that LDL be at 1.8. If we do increase statin dose or increase that LDL lowering, there is reason to believe that the risk will be lowered, but we will only be taking care of part of the non-HDL problem. LDL is the biggest part of non-HDL, but it is not the only part. And she will continue, despite having very well controlled LDL, she will continue to grow her atherosclerotic lesions because those other remnant particles will still be delivering cholesterol into the arterial wall. So this is not the best option in my view.
Okay. Thank you very much. I think this clear case to make us more understand how to put this perspective in daily practice, especially having those kind of patient. So thank you, Professor Agayar. Very clear explanation and case as well. So now we move to a second speaker today, is Professor Harmani. Yeah, Professor Harmani is our senior professor in the Department of Cardiology and Vascular Medicine, Universitas Indonesia. He has lots of experience in these fields. I would say he's one of our well-known clinical lipidologists and cardiologists as well, with lots of experience on both acute and chronic clinical cardiology cases in daily practice. So Professor Harmani would talk about the real-world evidence in the high-risk Asian population and how to apply risk optimization in our population. As you know, Asian population must be quite different with high, substantial number of patients with diabetes mellitus as well as patients with metabolic syndrome. So, Professor Harmani, time is yours, please.
Assalamualaikum warahmatullahi wabarakatuh. Selamat sore, salam sejahtera untuk teman-teman sekalian. Terdengar jelas ya suaranya ya. Jadi yang pada sore ini saya akan menyampaikan beberapa hal tentang apa yang harus kita lakukan dengan populasi kita yang risiko tinggi. Dan saya meneruskan apa yang telah disampaikan oleh Profesor Aguilar. Jadi konsepnya sama, saya akan meneruskan. Dan yang akan saya bahas adalah ada 7 poin di sini. Pertama tentang pasien yang risiko tinggi. Kedua sedikit tentang atherogenic dyslipidemia, seperti tadi disampaikan oleh Prof. Aguilar. Yang ketiga tentang review dari triglycerid. Ini adalah satu hal yang menarik karena trigliserida ini datang kembali. Dulu sudah kita lupakan. Sekarang ada review tahun 2019 dan 2020. Kemudian yang keempat tentang studi Eclipse Real yang merupakan pengalaman di Korea. Jadi ini real world study. Kemudian ada studi fenomibrat lain, bagaimana pendekatan pengobatannya, dan terakhir adalah take home message. Ini ada peringatan dari Robert Califf, tanggal 6 April 2021. Begitu kita sudah melewati fase akut dari pandemik, maka kita akan menghadapi gelombang kematian dan kecacatan yang besar karena penyakit kronik, terutama penyakit kardiometabolik. Dan ini kenapa? Karena selama pandemi banyak sekali pasien-pasien kita yang kurang diperhatikan. Pasien penyakit jantung, pasien hipertensi, gagal jantung, penyakit diabetes. Jadi ini adalah hal yang perlu kita perhatikan untuk mencegah jangan sampai terlalu banyak gelombang atau terlalu besar gelombang kematian dan kecacatan. Dan sebagai salah satu contoh, ini adalah pasien yang risiko tinggi. Seorang wanita umur 58 tahun dengan riwayat infark, hipertensi, dan gulanya pernah tinggi. Ini pasien baru yang datang ke poliklinik BPJS. Pemeriksaan fisiknya normal, kemudian HbA1c-nya 7,8%, gula darahnya 185. Yang menarik di sini adalah trigliserida 350, kolesterol total 200, LDL 105. Sepertinya ini tidak terlalu tinggi, HDL 25 dan non-HDL-nya 175. Jadi tadi oleh Profesor Aguilar sudah diberitahu bagaimana cara menghitung non-HDL, yaitu total kolesterol 200 dikurangi HDL. Jadi non-HDL 175. Oleh dokternya disuruh lifestyle, diet, olahraga, mengurangi berat badan, dan sebagainya, metformin, dan diberi ACE inhibitor. Mungkin kalau datang ke dokter jantung ditambah dengan aspirin ya, dan dia belum dikasih statin. Disuruh kembali 3 bulan, kita lihat di sini teman-teman, yang menarik adalah TG-nya turun, total kolesterolnya tetap, tapi LDL-nya naik menjadi 120, non-HDL 170. Jadi non-HDL turun sedikit, 175 menjadi 170, LDL-nya 120 setelah 3 bulan. Padahal sebelumnya LDL-nya di sini 105. Nah, kenapa LDL-nya naik? Bukannya malah turun 3 bulan setelah diet, olahraga, mengurangi gula, dan sebagainya. Nah, ini pasien-pasien BPJS, teman-teman tahu bahwa untuk mendapatkan LDL, mereka itu menghitung LDL dengan rumus Friedewald. Jadi untuk LDL yang pertama, ini rumus Friedewald-nya, total kolesterol dikurangi HDL, dikurangi trigliserid bagi 5, 105. Nah, setelah 3 bulan, LDL-nya total kolesterol dikurangi HDL, dikurangi trigliserid bagi 5. Jadi 120. Jadi ini teman-teman perlu lihat dan ingat bahwa LDL di pelayanan BPJS tidak diperiksa langsung, tapi dengan rumus Friedewald. Jadi dalam 3 bulan bukan turun, malah naik. Nah, ini dokternya cukup baik, dia mengobati dengan atorvastatin 20 mg. Setelah atorvastatin 30 mg, yang terjadi adalah LDL-nya turun menjadi 70 mg, non-HDL-nya masih 110. Jadi ini adalah total kolesterol 145 dikurangi HDL 35, non-HDL 110. LDL-nya 70 berdasarkan rumus Friedewald. Jadi teman-teman lihat bahwa setelah 3 bulan dengan atorvastatin turun 70 LDL-nya. Tapi non-HDL-nya masih jauh. Seperti Prof. Aguilar tadi, targetnya adalah 70 ditambah 30. Tapi teman-teman tahu bahwa pasien ini adalah pasien yang risikonya ekstrim. Ada DM, ada hipertensi, ada riwayat infark. Jadi LDL-nya harusnya 55 dan non-HDL-nya harusnya 80. Jadi apakah non-HDL berguna? Tadi slide dari Prof. Aguilar jelas non-HDL sangat berguna dihitung, terutama pada populasi ini. Dan menurut NCEP juga disebutkan bahwa non-HDL sekarang harus menjadi target pada pasien dengan TG lebih dari 200. Itu adalah pasien yang risiko tinggi. Teman-teman lihat bagaimana menggunakan non-HDL lebih banyak. Nah, metabolic syndrome itu adalah kumpulan dari gejala banyak sekali, ada 5, ada hipertensi, ada dislipidemia, ada obes, dan ada insulin resistant. Dan risiko kenaikannya tinggi, terutama karena ada atherogenic dyslipidemia yang ditandai dengan TG yang tinggi, small dense LDL, dan kolesterol yang rendah. Dan menurunkan LDL sebagai target memang bagus, tapi kadang-kadang tidak cukup untuk pasien yang seperti kita punya pasien metabolic syndrome. Nah, kenapa TG yang tinggi itu jelek? Ini slide-nya ada sedikit menjelaskan dari Prof. Aguilar tadi, bahwa kalau VLDL itu tinggi trigliserida, lipoproteinipase menjadi remnan. Dan remnan ini pertukaran TG dan kolesterolnya karena kolesterol ester transferase protein. Kolesterol ester transprotein. Jadi ini, kalau TG-nya tinggi, banyak yang ke sini. Karena TG dari LDL tinggi, gara-gara ditransfer TG terus oleh VLDL yang tinggi trigliserida, dia TG-nya diputuskan oleh hepatic lipase sehingga menjadi small. Begitu juga HDL, banyak TG-nya karena kolesterol ester transfer protein ini, kolesterolnya ke sana, TG-nya ke sini, dan ini menjadi target hepatic lipase small HDL. Yang ini lebih aterogenik, yang small HDL kurang fungsinya. Jadi kalau teman-teman lihat LDL, LDL itu partikel. Seperti tadi slide-nya Prof. Aguilar, dia seperti bus. Di dalamnya penumpangnya adalah ada kolesterol, ada ApoB. Nah, ini kolesterolnya kalau dari 2 partikel ini sama jumlahnya dengan kolesterol dalam 4 partikel ini. Jumlahnya sama kolesterolnya. Tapi yang beda adalah ApoB-nya ini 4, ApoB-nya di sini 2, dan juga dia lebih kecil. Kalau lebih kecil, LDL-nya susah disingkirkan dari plasma. Gampang masuk, karena tadi kecil, bisa masuk ke dalam subintima. Lebih cepat dioksidasi, dan lebih banyak partikelnya, yang menjadi lebih aterogenik. Nah, kemudian sampai kepada pembahasan tentang trigliserida. Jadi trigliserida ini barang lama yang sudah dianggap tidak penting, tapi pada tahun 2020 ada review yang baru. Karena sekarang lebih dianggap berperan penting pada penyakit aterosklerosis cardiovascular disease. Dari reviewnya tahun 2020, epidemiology and genetic study sudah membuktikan bahwa triglycerides lipoprotein dan remnannya tadi adalah VLDL, remnan VLDL, kilomikron, remnan kilomikron penting di dalam kontribusinya untuk ASCVD. Dan ini kenapa lipoprotein yang kaya triglyceride itu bisa menjadi satu sifat yang heterogenik, karena di sini dihancurkan oleh lipoprotein lipase menjadi remnan, dan remnannya masuk kemudian merangsang untuk menjadi makrofag, dan di sini adalah menjadi foam cell. Demikian juga setelah mendapatkan lipoprotein lipase, asam lemak bebas, kemudian di sini menjadi remnan dan mempunyai sifat koagulasi, endothelial dysfunction, mengganggu platelet dan sebagainya, sehingga dia kembali membentuk sel busa. Yang kedua adalah review tentang trigliserid tahun 2019. Jadi review ini adalah kesimpulannya di sini. Pada kontrol trial yang randomized, penurunan trigliserida berhubungan dengan penurunan major vascular event, kejadian vaskuler, bahkan setelah di-adjust dengan LDL lowering. Ini dulu adalah tidak pernah ada review 2 review ini, tahun 2019 dan 2020. Dan ini review yang penting, karena yang di-review banyak sekali studinya di sini. Jadi ada 44 studi yang berbagai studi dengan niacin, statin, fibrat, dan omega-3. Ini adalah hubungannya antara penurunan LDL dengan risiko. Teman-teman sudah tahu semua juga bahwa semakin rendah LDL, risiko semakin turun. Ini adalah studinya banyak sekali, dan yang bulat-bulat kecil ini adalah studi dengan fibrat, yang persegi 4 ini adalah statin, yang bulat ini adalah fibrat, Fahid, Daes, WHO, AHS, ini Helsinki Heart Study, ini Veteran Administration Heart Attack Intervention Trial, kemudian Daes ini diabetes, ini WHO, dan ini BIP, besa fibrat. Jadi ada beberapa studi di situ yang menunjukkan peranan dari fibrat, dan secara keseluruhan memang ada hubungan penurunan LDL dengan risiko MACE. Nah, kalau tadi adalah dengan LDL, ini hubungannya dengan non-HDL. Teman-teman lihat bahwa penurunan dengan non-HDL di sini lebih curam dibandingkan dengan LDL. Kita lihat lagi, ini adalah grafik hubungan LDL dengan risiko, sedangkan ini adalah grafik hubungan non-HDL dengan risiko. Teman-teman lihat bahwa hubungan antara non-HDL dan risiko adalah lebih curam dibandingkan dengan apa yang ditemukan dengan hubungan LDL dan risiko. Dan ini adalah tadi menyokong apa yang telah disampaikan oleh Prof. Aguilar, pentingnya untuk menilai non-HDL. Sedangkan untuk trigliserida, memang ada hubungan, tapi tidak securam hubungan non-HDL dan hubungan LDL. Jadi ini adalah hubungan antara penurunan trigliserida dan risiko. Semakin rendah trigliserida, risikonya semakin menurun. Dan seperti diketahui ini ada yang kotak adalah statin, kemudian yang niacin ini yang kuning, kemudian yang bulat ini adalah fibrat. Di sini ada akord, teman-teman tadi slide-nya sudah ada field dengan fibrat, kemudian besa fibrat, dan juga ada studi yang kecil yang lain, di sini Daes dan Fahid. Jadi kelihatan hubungannya kadar trigliserida dengan risiko. Nah, ini ada satu slide lain yang menunjukkan bagaimana peranan trigliserida. Teman-teman sudah sering baca studi Profetimi 22. Ini adalah studi pada orang dengan serangan jantung dan diberi atorvastatin 80 mg atau 40 mg. Bagaimana hasilnya? Jadi sebenarnya untuk menilai hasil terapi statin yang intensif dengan terapi yang tidak terlalu intensif. Tapi di sini dinilai hubungan antara trigliserida dengan risiko. Teman-teman lihat bahwa kalau semua pasien yang LDL-nya sudah di bawah 70, ini adalah semua pasien yang LDL-nya di bawah 70, kalau trigliserida lebih dari 200 setelah terapi, risikonya di sini. Kalau trigliserida di bawah 200, risikonya di sini. Jadi untuk pasien dengan LDL kurang dari 70 yang sudah mendapatkan statin, kalau TG-nya kurang dari 200, risikonya dia turun 36%. Karena relative risk-nya 64%, jadi relative risk reduction-nya 36%, dan ini P-nya sangat signifikan. Jadi ini menunjukkan pentingnya trigliserida pada pasien yang sudah dikontrol LDL-nya di bawah 70. Nah, berikutnya adalah sedikit studi tentang Eclipse. Jadi ini adalah penggunaan fenofibrat di dalam menurunkan outcome kardiovaskuler pada pasien yang sudah menggunakan statin pada pasien dengan sindroma metabolik. Ini satu studi yang baik sekali secara kohort dan dilakukan propensity match. Dilaporkan pada tahun 2019. Jadi ini adalah suatu studi yang besar dan dilaporkan dengan baik pada British Medical Journal. Teman-teman lihat bahwa sebagian besar studi dengan statin itu pada pasien populasi barat dengan risiko kardiovaskular yang tinggi. Sehingga kadang-kadang hasil itu tidak terlalu bisa diterapkan pada populasi yang golongan etnik yang lain. Dan juga pada pasien dengan berbagai tingkatan risiko kardiovaskular risk. Nah, karena atherogenic dyslipidemia lebih sering pada populasi Asia, karena adanya susceptibility genetik di mana TG-nya lebih susah dikeluarkan atau lebih susah di metabolismenya, maka studi pada populasi Asia dengan atherogenic dyslipidemia ini penting sekali. Dan ini adalah studi Eclipse yang mencoba menjawab permasalahan di sini. Karena ini belum pernah dijawab bagaimana peranan fenohidrat pada pasien dengan atherogenic dyslipidemia yang dilakukan secara besar. Apa bedanya dengan field dan accord lipid? Tadi Prof. Augulier sudah menyampaikan field dan accord lipid. Jadi ini adalah yang kita bedakan terutama pada field dan accord lipid itu kalau seluruh populasi hasilnya tidak signifikan. Tapi kalau pada dua studi ini dinilai pasien subpopulasi pasien dengan atherogenic dyslipidemia, yaitu TG-nya naik dan HDL-nya rendah, maka terdapat penurunan MACE yang signifikan dalam dua studi ini. Tapi secara keseluruhan, secara populasi keseluruhan memang tidak signifikan. Nah, beda yang kedua adalah pada Eclipse real study ini kadar trigliserid pada baseline lebih tinggi. Ini field dan accord 193 dan 162, sedangkan pada Eclipse real lebih tinggi. Dasar dari apa yang dinilai di dalam Korea dalam studi Eclipse adalah dari asuransi kesehatan di Korea. Jadi dasar populasinya besar sekali, yang di dalam asuransi itu 514.000, dan di dalam kohortnya ini dilakukan random selection 10% pada tahun 2003, 2002, 2003, dan follow-up-nya sampai 2015. Dan database ini sangat lengkap. Secara longitudinal, ada data medical, pharmaceutical, diagnosis penyakit, medical procedure, rumah sakit, dan data-data laboratorium, antropometrik, dan laboratori. Dan pasien yang dipilih adalah orang yang sudah lebih usia 40 tahun dengan database yang lengkap, dan pasien yang tidak ada data lipidnya dan tidak ada data statinnya dikeluarkan, dan mereka paling enggak 3 bulan menggunakan statin, minimal 3 bulan menggunakan statin dalam periode ini. Dan yang kedua adalah pasien yang diikutsertakan adalah pasien dengan metabolic syndrome. Ini adalah kriterianya: lingkaran perut lebih dari 90, TG 150, HDL kurang dari 40 atau 50 pada wanita, glukosa lebih dari 100, fasting, tekanan darah sekian. Jadi ini adalah kriteria metabolic syndrome yang biasa. Dan patient seleksinya di sini bahwa 1:5, akhirnya yang combined fenohidrat treatment di sini ada 2.156 pasien, sedangkan yang statin saja 8.500. Jadi ini dilakukan propensity score. Dan tujuan daripada penelitian ini adalah untuk melihat adalah penurunan cardiovascular risk pada pasien metabolic syndrome pada keadaan real world, pada praktek sehari-hari, di mana fenohidrat ditambahkan pada statin. Dan primary endpoint-nya penyakit jantung koroner. Jadi ini adalah infark, ischemic stroke, dan kematian karena kardiovaskulitis. Apakah karena stroke atau karena infark. Non-fatal infark, non-fatal stroke, dan kematian karena kardiovaskular. Ini diikutan di sini. Follow-up-nya hampir 30 bulan di sini. Jadi hampir kira-kira 2,5 tahun atau hampir 3 tahun di sini. Dan ini pasiennya di random dan dilakukan propensity match-nya di sini sebelum pasien itu dilakukan randomize. Jadi ini adalah cohort, studi cohort yang pasien diambil datanya dari asuransi di Korea. Disampling dari 500.000 orang, 10% ya tadi. Dan ini propensity score matching ini adalah satu metode kuasi eksperimental. Jadi pada observasi yang cohort, jadi bukan betul-betul eksperimental, tapi juga membandingkan intervensi yang dipergunakan, yang menggunakan statistik, teknik statistik untuk membuat kontrol yang artifisial dengan matching setiap treated dengan non-treated. Jadi dengan match ini maka kita bisa memperkirakan hasil dari intervensi. Jadi tujuan propensity score match ini adalah untuk mengurangi efek dari confounding. Dan untuk propensity score banyak sekali variabel yang dimasukkan. Ini semuanya variabel yang dimasukkan di dalam menghitung skor dari propensity. Untuk yang combined treatment dan statin treatment, skornya harus sama. Jadi ada jarak tertentu yang bisa diterima setelah skor ditentukan dengan memasukkan semua variabel. Usia, jenis kelamin, lingkaran perut, kreatinin, alcohol compensation, penggunaan statin berapa lama, antihipertensi, dan semua di sini yang dianggap mempunyai faktor yang penting untuk menyebabkan cardiovascular mortality atau morbidity. Jadi ini semua confounding dimasukkan di sini. Ini slide-nya terlalu kecil, tapi mau menunjukkan bahwa sebenarnya antara yang combined treatment dan yang statin treatment itu populasinya hampir sama semuanya. Yang berbeda adalah hanya penggunaan beta blocker dan penggunaan diuretik. Kemudian bagaimana hasil lipidnya? Ada hasil LDL, HDL, dan trigliserida, dan non-HDL. Teman-teman mungkin lihat angka yang di baris pertama di sini. Dan yang berbeda adalah trigliserida di sini. Ini adalah on treatment 1,64, sedangkan yang di sini on treatment 1,85. Yang berbeda sangat signifikan adalah penurunan trigliserida. Sedangkan HDL bedanya ada, ini 133 di sini on treatment, di sini 128. LDL-nya lebih tinggi pada yang combine, 256 di sini 248. Dan non HDL di sini 328, 332. Jadi teman-teman lihat yang paling besar perbedaannya adalah pada trigliserida on treatment yang combine dan sini on treatment yang single atau dengan statin aja. Hasilnya bagaimana mengenai komposit cardiovascular event-nya? Jadi di sini kalau untuk semua pasien, all patient, terdapat perbedaan yang signifikan. Ini adalah 74%. Mungkin teman-teman nggak terlalu bisa melihat, tapi hazard ratio-nya adalah 74%, jadi penurunannya 26%, dan confidence intervalnya tidak melewati 1, jadi signifikan. Ini untuk semua pasien. Ini kalau pasien dengan yang low HDL dan high TG, perbedaannya lebih besar lagi. Di sini hazard ratio-nya 0,64%, jadi turunnya 36%. Kalau ini turun 36%, di sini turun 24%. Jadi kalau pasien di dalam metabolic syndrome, ada juga yang LDL-nya nggak rendah, TG-nya nggak terlalu tinggi, tapi kalau dua kriteria dimenuhi, salah satunya ya, low HDL atau high TG pada metabolic syndrome, menurunnya lebih besar. Sedangkan kalau yang HDL-nya tinggi dan TG-nya rendah, tidak signifikan. Jadi ini ada nilai-nilainya. Kalau kita lihat individual outcome-nya, coronary heart disease, ischemic stroke, cardiovascular death, di sini tidak signifikan perbedaannya. Karena semuanya melampaui 1. Tapi kalau komposit di sini turun 36%, di sini turun ini 26%, di sini 37%. Jadi kalau pasien masih on treatment 37%, kalau sudah berhenti pengobatannya 26%. Jadi kita lihat angkanya tadi di dalam tabel kurang jelas barangkali. Jadi tabel tadi menunjukkan incident rate per 1.000 orang per years. Di sini kalau coronary heart disease individualnya Hazard ratio 82%, tapi P-nya 0,2, jadi tidak signifikan. Ischemic stroke 74%, tapi tidak signifikan. CVD death juga tidak signifikan. Jadi 3 kejadian yang secara tersendiri, individual komponen, tidak signifikan. Tapi kalau digabung, dia akan menjadi signifikan di dalam 2 kelompok tadi. Combined treatment group itu lebih rendah, hazard ratio 0,74 dengan P yang jauh di bawah 0,05, P-nya 0,01. Kalau yang masih on treatment 63%. Jadi adalah kesimpulannya teman-teman sekalian bahwa pada studi Eclipse terdapat penurunan 26%, median TG-nya pada Eclipse itu 208, pada Field dan Accord itu lebih rendah, 153, 116, ini bukan 1162 tapi 162. Jadi ini adalah lebih rendah daripada Eclipse. Sama similar untuk kenaikan enzim maupun perubahan kreatinin di sini. Jadi safety-nya baik, kombinasi fenofibrat dengan statin. Dan kenapa fenofibrat bisa menurunkan mortality morbidity? Ini karena dia mempunyai efek menaikkan HDL, menurunkan VLDL, terutama di sini adalah menurunkan TG. Jadi teman-teman lihat tadi yang paling bermakna adalah penurunan TG pada studi Eclipse. HDL-nya berbeda sedikit, dan di sini juga merubah fungsi dari CETP. Teman-teman ingat bahwa kolesterol ester transfer protein ini adalah yang menukarkan kolesterol trigliserida di antara partikel yang kaya lipoprotein dengan LDL dan HDL. Ini yang bertanggung jawab untuk terjadinya small dan dense particle LDL. Studi-studi fibrat yang lama ada, ini adalah Helsinki Heart Study dengan Kimfirusil, ini besafibrate infarction prevention trial dengan besafibrate, Field pada orang DM, fenofibrat, Accord pada orang DM. Kalau ini hanya fenofibrat, kalau ini kombinasi fenofibrat dengan statin, sedangkan ini studi terakhir tadi Korea Study fenofibrat dengan statin dibandingkan dengan fenofibrat saja. Teman-teman lihat, kalau lihat subgrup ini, subgrupnya hampir sama semua, TG-nya sekian, LD-nya ini TG-nya kalau tinggi, TG tinggi, HDL kurang. Kalau di sini hasilnya tidak signifikan, karena P-nya 0,24, P-nya 16, P-nya 0,32, hanya ini yang agak signifikan. Tapi kalau subgrup yang ini yang dianalisa, selalu penurunannya besar dan signifikan. 71%, 40%, 27%, 31%, 30%. Jadi sebenarnya fibrat itu konsisten di dalam berbagai studi menurunkan kejadian kardiak mayor pada kelompok yang TG tinggi, HDL rendah. Dan ini ada beberapa slide yang terakhir. Di dalam makalah dari Gurundi tahun 2019, di dalam cek, ini dianjurkan bagaimana kita restratifikasinya. Restratifikasinya di sini ada usia, kemudian ada penyakit aterosklerotik atau tidak, dan kemudian perhitungan risiko secara skor di sini. Dan teman-teman lihat bahwa di sebelah kiri ini adalah faktor yang meningkatkan risiko. Jadi risk enhancer pada kejadian ASCD, aterosklerotik cardiovascular disease. Dan di sini teman lihat, salah satu risk enhancer adalah persistently elevated TG. Jadi kalau TG lebih dari 170, sebenarnya bukan 170, pada berbagai studi itu adalah 150, tapi di sini di dalam jurnal JACC tahun 2019 disebutkan persistently elevated TG lebih dari 175, ini meningkatkan risiko enhancer dibandingkan ditambah dengan risiko-risiko yang ada di sini. Dan risk enhancer yang lain adalah CRP, lipoprotein little a, ApoB, dan ankle brachial index. Ada skema yang lain, bagaimana kalau TG tinggi. Jadi kalau TG tinggi lebih dari 150 atau lebih dari 200, kalau TG-nya tinggi, ini non-HDL menjadi target. Dia dilihat, non-HDL tidak tercapai target, TG-nya naik, ini kurang dari 10 milimol ini, kalau dikalikan 88 jadi kira-kira 900 miligram, jadi semua trigliserida yang di bawah 900 miligram itu ke sini, tapi kalau udah tinggi harus ke sini, karena ini risikonya pankreatitis. Sedangkan ya di sini berhubungannya dengan penyakit kardiovaskuler. Dan teman-teman lihat di sini perlu dilakukan penurunan LDL yang lebih lanjut dan perlu dipertimbangkan pemberian fibrat dan atau omega 3 fatty acid. Ini adalah dengan dosis yang tinggi 2-4 gram dan ini kalau yang asli harganya mahal sekali. Jadi pertimbangannya adalah fibrat atau omega 3 fatty acid sini. Jadi take home message ini slide yang terakhir, teman-teman, bahwa populasi Asia mempunyai risiko metabolik untuk terjadinya hipertriglisemia dan sindrom metabolik yang lebih tinggi daripada kelompok populasi yang lain. Dan peserta studi di dalam Expedia merupakan contoh kandidat yang baik untuk kombinasi pengobatan dengan fenofibrat. Dan risiko MACE menurun secara signifikan pada pasien yang mendapat fenofibrat yang ditambahkan pada statin dibandingkan dengan statin saja pada pasien dengan metabolic syndrome atau dengan atherogenic dyslipidemia. Dan ini adalah yang review yang baru bahwa di dalam randomized control trial penurunan trigliserida menurunkan risiko vascular event meskipun ataupun setelah disesuaikan dengan penurunan LDL. Terima kasih untuk perhatian teman-teman sekalian. Wassalamualaikum warahmatullahi wabarakatuh.
Oke, terima kasih. Thank you, Professor Harmani. Professor Harmani described us inside of this concept what we discussed today about the non-HDL and atherogenic dyslipidemia in our population, in Asian population, which has probably not that similar background, demographic background to those with other ethnics, different ethnics in the world, such as Caucasian. So it's very clear explanation and seeing the patient what we have in daily practice, that what we have in routinely. So this is how to incorporate this concept in our daily practice. So now we were moving to discussion. There's already some question here from our colleagues here. I would start with, I think this is first question from Dr. Ricky Aditya. Which statin, whether it is simvastatin, rosuva, or other statin, is the best in combination with fenofibrate or omega-1 in patient with high LDL level and high TG level as well, in counting the unpleasant side effects. So to at the same time, it's possible. So there are two issues here, whether the safety of combination of statin and fibrat, and which the best statin to combine for this treatment. So please, please, Professor Aguirre.
Thank you for this question. So there is no extra side effects when you combine fenofibrate with any of the 7 statins that are available around the world. The only exception is liver enzymes, which may increase slightly more often if you are taking combination therapy than if you are taking a statin alone. That is the only side effect that you get from combination of fenofibrate on top of a statin. Now, fenofibrate has absolutely no interactions with any of the statins. So this means that if a patient has muscle symptoms, myalgia, or even rhabdomyolysis, it is not being caused by the combination of fenofibrate with the statin. It is being caused by the statin because the combination does not increase the rates of muscle side effects. It also does not increase the rates of CK elevations, of the muscle enzyme elevations. It's exactly the same. So it doesn't matter which statin you use, the side effects will be the same as they were with the statin alone if you combine fenofibrate. But it is very important that you only combine fenofibrate with a statin because the safety is only there with fenofibrate.
What about, there are some question also about so you can use any statin for the combination that by taking into account the level of LDL of each patient.
Absolutely, right? Yes.
Dr. Harmani, do you have any comment on this and your experience so far using this combination before?
Bahasa Indonesia aja ya.
Yeah, please, bahasa Indonesia or language.
Jadi untuk pertanyaan yang bagus sekali tadi, bagaimana kombinasi statin dengan fenofibrat. Ada dua hal sini. Yang pertama yaitu mengenai safety. Jadi memang yang boleh digabung hanya this only fenofibrat. We can combine only fenofibrat with other statin. And the second is about the efficacy. Tergantung dari penggunaan pada pasien apa. If you are going to use that for high-risk patient, then there are only two options. Either you will have to use rosuvastatin or atorvastatin. Jadi kalau memang sudah pasiennya itu risiko tinggi, kita tidak boleh milih apa saja, kita cuma milih atorvastatin, rosuvastatin. Kalau risikonya rendah memang bisa pakai pitavastatin, fluvastatin, pravastatin, kemudian juga ada yang simvastatin. Jadi kalau yang risiko tinggi, cuman sayangnya di BPJS yang di cover kebanyakan simvastatin sama atorvastatin. Jadi memang itu. Yang kalau safety memang itu sebenarnya untuk tiap-tiap statin beda. Hepatoselectivity dan muscle selectivity. Jadi yang termasuk yang itu memang rosuvastatin. Yang hepatoselectivity dan muscle selectivity-nya itu paling baik adalah rosuvastatin karena kita ingin statin kita bekerja di sel hepar. Tidak terlalu banyak bekerja di sel otot. Saya rasa itu. Dua itu ya.
Oke. Makasih, thank you, Professor Harmani. This is another, I think, good question from Dr. Bayusi. Dr. Bayusi is one of our senior fellow resident in our center. He's asking about, can we combine low-dose statin and fenofibrat early in the course of the disease, considering that non-HDL level is normal? Is there any safety concern? So be aware of using this combination from early. So given that, for example, in the UK, now the non-HDL is the real target used in dyslipidemia. So can we apply this in the early course of the disease? That's a very important question. Please, yourself, Professor Aguirre.
Yes, we can. And, you know, it's difficult to understand what is early because when we're speaking about patients with type 2 diabetes, We think that sometimes, we often think they're primary prevention patients because they have never had a myocardial infarction or a stroke. They have never had chest pain, anything that would make us think that they have cardiovascular disease. But many primary prevention patients with type 2 diabetes, if you check their coronary arteries and their carotids, you will very, very often find evidence, imaging evidence of significant atherosclerosis. So it's very difficult to say that treating a diabetic patient is early when they are in primary prevention. Most likely they already have significant atherosclerosis in their arteries, and so it's always important to start as early as possible. Now, I just have one additional comment about the low dose of statin. It's okay to use a low dose of a statin or a less potent statin if your patient does not tolerate a higher dose, a more potent statin. But you will very likely have to join ezetimibe in order to reach that LDL target. So what is important is to not forget to also reach the LDL target. The reason why I prefer the European guidelines and the American endocrinology guidelines to the UK guidelines is because the Europeans and the Americans say, look at LDL and look at non-HDL. Not only looking at the non-HDL, we need to look at both, because non-HDL can be high when patients have little LDL but lots of the remnant particles, or it can be high because it's a lot of the LDL and very small amounts of the remnant particles. And the way you treat this is different. If it's LDL that is predominant and triglycerides are normal, you will treat non-HDL by lowering LDL. That statins is maybe with ezetimibe, maybe in special cases with PCSK9 inhibitors. If there is a problem with the remnant particles, with the high triglycerides, you will have to take care of the LDL, and at some point you need to take care of the triglycerides as well. Otherwise, you're only taking care of one of the enemies when there are two.
Okay, it's a clear explanation. Thank you, Professor Guerra. And Professor Harmony, this is a question is from a cardiologist here. In the daily practice, there are lots of variation on prescribing fenofibrate in hyper-TG. Some started after on patient after reach target 150. Some started the use of fibrates when the patient coming with TG above 400. What's the best way to solve this problem, and what's the best approach on these cases, Professor Harmony?
I think this is a very interesting question. You know, when we look at the study, actually, when TG above 150, the LDL is getting smaller and dense. So actually, when TG is above 150, then you will have more small and dense LDL. So that's why actually you don't have to wait for the TG to get higher, 400 or 300 or 250. Once, especially in patient with diabetic and in patient with metabolic syndrome, once you see TG more than 150, you will have to suspect that the patient has small and dense LDL. And that is not good for the patient, even though the LDL is not as high. Just like my patient, when she came, the LDL is only 105 milligram per deciliter, and TG is about 350. But actually, you don't have to wait for 350. Suppose you found your patient 200 or 150, and then in metabolic syndrome and patient with diabetes, you will give fenofibrate to expect that you will change the small dense LDL in this patient, and you will get large and buoyant LDL, and also you will also change the HDL. The HDL will get bigger rather than small HDL, because small HDL will be easier to get rid from the body through kidney extraction. So that is good, and you can start giving fibrate. There are only, I think, 2 fibrate that is recommended to combine with statin, but most of the study use fenofibrate. Yeah.
Yeah. Thank you, Professor Harmani. And continuing this question, Professor Aguirre, I just think about that. Our guideline always stated that we have to reach LDL level target below the recommended guideline level, and then start to start TG as a secondary target. But as you mentioned, non-HDL is very important target as well, and there are some consideration even a better target to reduce the possibility of high CV events. So would you really in the practice suggesting starting the combination after the reaching the HDL or target, or just for certain patients, for example, those with diabetes and a patient with metabolic syndrome, for example, then we can start early combination as early as possible, both statin and fibrate. Please give the comment, Professor Aguirre.
Thank you. This is an extremely important question, because if we read the guidelines and only do exactly what the guidelines say, we should first get LDL controlled and only then look at non-HDL. Now, the problem with this, as you have said, many times we cannot reach those LDL targets. They are lower and lower as the years go by. Guidelines have been pushing the LDL to lower levels, and it's not easy in the real world to control LDL that well. And it's especially hard if we do not use ezetimibe on top of statin therapy. Now, when you cannot reach that LDL goal, the worst thing you can do for your patient is to not only leave him or her with a not well-controlled LDL, but also to leave him or her with a not well-controlled non-HDL, because you're not going to do nothing for the non-HDL because you have still not reached the target for LDL. Indeed, at any level of LDL, any level, so even when it's not well controlled, if the non-HDL is more than 30 above the LDL, your patient is in trouble. Those LDL and HDL and VLDL particles are all being changed by CETP, and there is an additional source of cholesterol going into the arteries and not only the LDL. That's true for any level of LDL. So what do I do in my patients? I first of all try my best to get LDL well controlled. I give them a good statin. I try to give them the best statin possible for them to see if they tolerate it. I add ezetimibe if needed. But if I cannot do more than that, and we do have PCSK9 inhibitors in our country, but because of their price, they are only being given to very specific patients. If I cannot do any more than that, I won't leave myself stuck just because the LDL is not where it should be by the guidelines. I start looking at the non-HDL. And if it's more than 30 above the LDL, I will put fenofibrate on top of what I am doing for the LDL, which many times will be a statin with ezetimibe. So I join the fenofibrate. And there is no problem of interactions between these three, statin, ezetimibe, and fenofibrate. They work very well together without increasing the risk of side effects.
Yeah, it's very clear explanation, especially here in Indonesia. Sometimes difficult for us to have patient reach their target. So when we treat the patient individually, it's because of the constraint of availability of drugs that covered by insurance, for example. It's sometimes very difficult to reach the target as mentioned by guidelines, given the fact that now the level of DL, every single guideline tend to lower, and lower. Even the combined with ezetimibe sometimes cannot solve the problem. So there's very important. You mentioned about the possibility of posing our patient in the subspecial risk when we cannot reach the target. So then non-HDL is very important target to be used in our practice. So there are questions also still. We have time. I would like to highlight this is very conceptual question from Dr. Jetty. Dr. Jetty is one of our senior cardiologists from our center. Please give your comments, both Professor. This is very conceptual concept of the non-HDL here in our population in Indonesia. As you know, in Asian population like here in Indonesia, there are lots of high carbohydrate intake, which proportions mostly higher than protein and lipid in daily diet. So this would increase the risk of ACVD because the catabolism of carbohydrate will increase LDL. And what's but the non-HDL? So the question is whether this pattern of diet would clearly increase the non-HDL. Please give a comment, Professor Guerra and Professor Harmani. Please, you mute your, please.
Professor Harmani can kick off with the answer.
Professor Aguilar, you are very polite.
What's your comment first? And so I would say this is we can have point of view from expert of Europe and Asian expert.
Yeah, I will give you my point of view. Yes. I very much enjoy the carbohydrates from Indonesia. They are delicious, very, very good.
Yes.
So, now, without joking, I also come from, in our country, we also have quite alarming rates of diabetes, not as much as in Middle East and Southeast Asia, but we're also very concerned. We don't eat too much carbohydrates.
Yes.
It's more the fats, but we do have alarming rates. And we need to change those dietary habits and re-educate the population, starting from very young at school. At school, the children, that's the right age to really start influencing them into getting more healthier lifestyle.
Yes.
Professor Ramli, please.
Yeah, I think this is very good question, because rice is our main staple. But there are so many results of studies and research that show that white rice is actually has a one of the highest glycemic index. So carbohydrate with high glycemic index, I think will have more effect on the metabolic syndrome, obesity, triglyceride, and so on. And also, because it has been shown. So there are more diabetes patients in Southeast Asia. Also, I think in Indonesia is increasing now obesity, diabetes, and metabolic syndrome. And one of the reason is probably because our main staple is white rice. But you know, it's difficult to change the habit of people, and then we have to start thinking about giving people more option about the carbohydrate. So I think when we use white rice, your concept of non-HDL is more relevant. You know, we know that non-HDL is very important. It has a stronger relationship with CVD as compared to LDL. But we have to be frank that this non-HDL cholesterol concept has not been utilized or applied in many clinical practice in our country. Because one, they don't know actually the simple thing of how to calculate non-HDL. As you told us, it is just total cholesterol minus HDL. And then they don't know the stronger relationship of non-HDL to CVD. And then they don't know what to do with non-HDL. I think when we have to give doctors about this concept of non-HDL, then probably the control of dyslipidemia atherogenic will be better, you know, in clinical practice.
Yeah, thank you very much. These are, I think this is not a practical question come from, I think, two of our colleagues. What about how to treat TG or non-HDL cholesterol in those with CKD, chronic kidney disease? What's the option of this? Is this safe to give that medication? And there are also clinical question here. What if they use a fibrate, then but the TG still high? So this is two different questions, but please address this your experience, both Professor Aguirre and Professor Arman, please.
Well, I can say to you about CKD the following. So in chronic kidney disease stage 3 and 4, it is very common to find mixed dyslipidemia. So this
mixed dyslipidemia, yeah.
Dyslipidemia profile is very common in stage 3 and 4. Now, stage 3 chronic kidney disease is the most common, the most prevalent stage of chronic kidney disease found in the general population. So it's a large number of people. It's about 10% of a country's population. So it's a very large group of people who have stage 3 chronic kidney disease. It is safe to use fenofibrate up to a GFR of 30. I do it, but for a GFR in between 30 and 45, I prefer to use every other day dosing. So I miss a day for each day that I give it. So one day yes, one day no, one day yes, one day no.
Oh yeah.
In order to not cause toxicity from the fibrate. The fibrate that can be used up to a GFR of 15 is gemfibrozil. But gemfibrozil has significant interactions with all statins. And these interactions increase significantly the risk of rhabdomyolysis. So we cannot use gemfibrozil with any statin at all. In other words, when renal function becomes too impaired, too advanced, we will have to start using omega-3 fatty acids instead of fibrates to treat the high triglycerides. But it is safe to use fenofibrate down to 45 at least, but in between 30 and 45, it's best to use only once every other day. Now, the other question was on... we cannot hear you. Dr. Renan?
But still, the level of TG still high when they use when you use fenofibrate, especially 300 milligrams. So would you recommend other approach on this?
Yeah, so what I do is I combine omega-3 fatty acids with the fenofibrate in those cases. The problem about omega-3 fatty acids is that to really be effective at reducing triglycerides, you need to use high doses. And this increases the cost. You know, it's much more expensive, at least in my country, to use omega-3 fatty acids than to use fenofibrate, especially because you're going to have to do 2 to 4 grams a day. And so it becomes quite an expensive treatment. But that's the only real option we have thus far, is to combine omega-3 fatty acids with the fibrate. Then dietary counseling is very important. So when I get into that kind of trouble, I have the patients see the dietitian in order to have a thorough check of the dietary habits and see if there are things that can and should be changed. And there often are.
Yeah, thank you. This your clear explanation also answer there was a question about the combination of statin and gamfibrozil, because that what available in our public medical center. Then you clearly mentioned that this will be danger because this would increase the risk of rhabdomyolysis. So yeah, I think I would go to the last question, but this is very important also. Please give your expert opinion on this, because we are now in the era of pandemic. It is a question posed by Dr. Anwar Santoso. Dr. Anwar Santoso is one of our expert in this field, actually. He's also one of a panel expert on our national board of drug agents. So like Indonesian, what we call Indonesian POM. Yeah, POM is Food and Drugs Agency. So he's one of expert on this. And the question is, because we are in the era of pandemic, do you believe that statin and also probably fibrate will impair the immunogenicity of the COVID-19 vaccinated people who previously consumed statin? So in the big picture, what your both opinion on the use of this high cholesterol agents such as statin or also fibrate on this pandemic era? This is whether this will impact happen on COVID-19 and also will have an impact also for those already vaccinated. Please, who first, Professor Harmani or Professor Guia?
So I'm not an expert in immunology, but I would dare say that there is no reason to think that statins or other lipid-lowering agents would impair the immunogenicity of the vaccinations. And I would actually argue in favor of, if you are a patient at high risk or very high risk for cardiovascular disease, that by taking the right lipid-lowering therapy, whether it be statin only or statin in combination with fenofibrate, you're certainly going to be less inflammatory. You're going to have a much more healthier systemic environment, which will allow you to better react in case you do have an infection. It's terrible to be pro-inflammatory when you are suddenly affected by a virus like this one that really enjoys very much that excess of inflammation to really cause the disastrous consequences that we see. On the other hand, I would also present forward the argument that in countries like mine, but we're not so advanced in our immunization, but the UK, which is very advanced, they think they will reach herd immunity this month of April. they've also given priority to vaccination of the high-risk patients. And what they're already seeing is very marked reductions in the rates of hospitalizations and hospitalizations in ICUs, which typically are for those COVID-19 cases where you have high risk for cardiovascular disease patients. So the obese, the diabetic, hypertensive with cardiovascular disease that is already well established. So I think this actually tells us that we can trust that these high-risk patients for cardiovascular disease are being well protected by the vaccine, despite all their background therapy, that they're taking for blood pressure, for lipid lowering, for diabetes control, and so on.
Thank you very much. Professor Hamani, please give your expert opinion on this.
Yeah, I think this is very good question, especially the use of statin in the COVID epidemic. But because when we look at the many studies and the properties of statin actually is beneficial in patients with COVID. And because there are several effects of statin, and for example, this anti-inflammatory and oxidative stress, this has pleiotropic effect on inflammation and oxidative stress, and also modulate the immune response at different level. So we expect that actually statin will at least it's not harmful to patients with infection of COVID-19 at the moment. So patients who took statin, we encourage them to continue their statin treatment when they get COVID or even during COVID epidemic. So that is one, yeah.
Thank you, Professor Harman and Professor Han, for this question, because it's clear that any medication would be important for each patient, and the risk of the benefit of having vaccination is clearly outweigh the risk of any medication that we have. So this is also gives some insight to our audience here that any medication, cardiovascular medication, whether it's combination of statin and fibrate, for example, you still need to give the patient blood medication also in order to prepare our patients to better control, to better lower inflammation in this pandemic era. I think by this question, I will close this QA because we already exceeded 4 p.m. and I would thanks this to great our teacher, I would say, big great lectures to give us insight on the, how to treat dyslipidemia in very logic way and with the better approach, because we are now in the era of personalized medicine. We are in the era of having a personalized therapy to our patient. So it's very important to see the patients individually. And we have non-HDL as probably similar or better target in treating patient dyslipidemia, and combination of statin and fibrate, for example, for instance, in these situations, it's very important to be given even as early as possible to decrease the chance of having cardiovascular disease and even in the future. For that, I would again thank you, Professor Aguirre, for this time, and then I hope to see you again in our webinar or meeting and some time in the future, and also Professor Harmani. And also thank you for our colleagues from Abbott that provide us possibility to have this event. And for those all of you, my colleagues who join this meeting, almost 400 audience coming from throughout Indonesia, join this important meeting even in this Sunday afternoon, yeah, in our family day. But again, we learn lots this. We are in the era of pandemic, and we have to give the best treatment to our patients whatever we can. Again, for this, I want to conclude our meeting. Thank you very much, everybody. Professor Aguirre, for example,
Thank you.
Specifically, and have a nice time. Keep safe, everyone. See you in the next meeting, our meeting from Indonesian Cardiovascular Foundation and Department of Cardiology and Vascular Medicine, University of Indonesia, University Indonesia at Harapan International Heart Center, and University Indonesia Hospital. Thank you very much. See you. Bye-bye.
Thank you. Bye-bye to all. Thank you.
Jadi kita masih merah ya.
Negeri elok amat ku cinta,
tanah tumpah darahku yang mulia,
yang ku puja sepanjang masa.
tanah airku aman dan makmur,
Pulau kelapa yang amat subur,
pulau melati pujian bangsa sejak dulu kala. Hidup di pantai terbisik-bisik,
Raja Kelana
surya di cakrawala,
pulau nan indah bermain,
dan airku Indonesia.
bukan lautan hanya kolam susu, kain dan jala cukup menghidupimu. Tiada badai, tiada tempat kau temui, ikan dan udang menghampiri dirimu. Hidup di pantai terbisik-bisik, Raja Kana bersatulah semua seperti
Dahulu lihatlah semua keinginanmu telah terjangkau semua.
negeri elok amat ku cinta.
Tanah tumpah darahku yang mulia,
yang ku puja sepanjang masa.
tanah airku aman dan makmur.
Pulau kelapa yang amat subur,
Pulau melati pujian bangsa sejak dulu kala. Hidup di pantai berbisik-bisik.
Raja Kelana,
Surya di cakrawala.
pulau nan indah bermain.
Indonesia,
Bukan lautan, hanya kolam susu. Kain dan jala cukup menghidupimu. Tiada badai, tiada tempat kau temui. Ikan